Good morning, class. The topic for the day is paramyxoviruses. Myxoviruses are a group of viruses that bind to mucin receptors on the surface of RBCs. That is myxo in Greek meaning mucin, resulting in clumping of RBCs together to cause heme agglutination. Objective: to understand myxoviruses, their morphology, pathogenesis, and laboratory diagnosis. Now, Paramyxoviridae. Paramyxoviridae contains a group of viruses which are transmitted via the respiratory route, following which they may cause localized respiratory infection in children, or they may disseminate throughout the body to cause highly contagious disease of childhood such as mumps, that is parotid enlargement, and measles, that is rashes. Now, morphology of the paramyxoviruses. Paramyxovirus resemble orthomyxovirus in their morphology but are larger and more pleomorphic. Their size vary from 100 to 300 nanometer and rarely up to 800 nanometer. They possess a helical nucleocapsid. Contains single-stranded RNA which is linear, non-segment and negative sense. They contain 6 structural proteins which forms capsid, polymerase, matrix proteins that underlies the viral envelope, and envelope glycoproteins. Envelope. The nucleocapsid is surrounded by a host-derived lipid envelope in which the virus-coded polymers, that is, papillomas glycoproteins, are inserted. Various genera: Paramyxovirus containing parainfluenza type 1 and type 3, rubella virus, parainfluenza type 2, parainfluenza type 4, and mumps virus. Morbillivirus, that is measles virus, and pneumovirus, respiratory syncytial virus. Now, parainfluenza viruses. Human parainfluenza viruses are one of the major causes of lower respiratory tract disease in younger children. It has about 5 serotypes. Pathogenesis and clinical manifestation. Transmission is by respiratory route, by direct salivary contact, or by large droplet aerosols. Their incubation period is about 5 to 6 days. Virus multiplies locally and cause various respiratory manifestations. Various clinical manifestations include mild cold syndrome like rhinitis and pharyngitis are the most common presentation. Then CROP, that is laryngotracheobronchitis, occur in 2 to 3% of cases. That is mainly in infants and young children, severe respiratory tract disease like pneumonia and bronchiolitis. In older children, laryngotracheobronchitis or CROP, which is associated with common cold, fever, cough, respiratory obstruction due to swelling of larynx, related structures. In immunocompromised children, severe infection. Reinfection is mild. Otitis media. It is the most common complication of parainfluenza viral infections. There is no cross protection between the serotypes. That is an important point. Immunocompromised people are susceptible to severe infections. In older children and adults, disease is milder. Laboratory diagnosis. Antigen detection is done. Viral isolation is done in primary monkey kidney cell line. Serum antibodies can be detected, and reverse transcriptase PCR assays are highly specific and sensitive but available only in limited settings. Animal parainfluenza viruses are there. Certain animal parainfluenza virus are related to the human strains. Next one is mumps. Mumps virus is the most common cause of parotid gland enlargement in children. In severe cases, it can also cause orchitis and aseptic meningitis. Mumps virus that is causing mumps is predominantly disease of childhood, parotid enlargement in children, severe case orchitis and aseptic meningitis. Mode of transmission: respiratory route or conjunctiva, infected saliva, aerosols, and fomites. Pathogenesis. Primary replication occurs in the nasal mucosa or upper respiratory mucosa, infects mononuclear cells and regional lymph nodes, spills over to bloodstream resulting in viremia and finally dissemination. Target sites: That is, mum virus has a special affinity for glandular epithelium. The classic sites include salivary gland, testis, pancreas, ovaries, mammary glands, and central nervous system. Incubation period is about 19 days, that is a range between 7 to 23 days. In apparent infection, up to half of the infected people are either asymptomatic or present with non-specific symptoms such as fever, myalgia, and anorexia. This is more common in adults than in children. Bilateral parotitis. Acute non-suppurative parotid gland enlargement is the most common specific manifestation, which is present in about 70 to 90% of cases. Rarely, parotitis may be unilateral, and other manifestations include epidermoorchitis is the next most common manifestation of mumps, developing in about 15 to 30% of cases in post-pubertal males. Orchitis is unilateral in most of the cases, hence infertility following mumps orchitis is rare. Oophorytis occurs in about 5% of women. Aseptic meningitis occurs in less than 10% of cases with a male predominance. It is self-limiting. Pancreatitis occurs in 4% of infections and may lead to diabetes. Atypical mumps, parotitis may be absent in 10% of cases and patients directly present with aseptic meningitis. This is a picture of mumps with parotid gland swelling. Diagnosis. The buccal or oral swab are used as specimens. Also, most other ideal specimens include saliva, CSF, urine, seminal fluid, and rarely blood. Direct viral antigen detection can be done by using mumps-specific immunofluorescence staining of clinical specimen. Virus isolation by monkey kidney cells are preferred cell lines. Specimens should be inoculated immediately. Serum antibody detection. ELISA is the most widely used assay. Reverse transcription PCR is available to detect mumps-specific RNA such as N gene in clinical specimen. Genotyping is done targeting the small hydrophobic gene. Serology, we can see a fourfold rise in antibody titer in ELISA, that is IgM and IgG. Antibody versus S antigen, which shows a current infection, and antibody versus V antigen, which is showing a past infection. Vaccination. Live attenuated vaccine, that is Gerald-Lynn strain. Live attenuated Gerald-Lynn strain is a recommended strain used worldwide. Mumps vaccine is prepared in chick embryo cell. They are available as trivalent MMR vaccine, that is live attenuated measles, mumps, rubella vaccine, or quadrivalent MMR V vaccine, that is contains additional live attenuated varicella vaccine. Monovalent mumps vaccine is not recommended. Then schedule. 2 doses of MMR is given by subcutaneous route at 1 year, that is 12 to 15 months, and 4 to 6 years before starting of school. And efficacy is about 88% after the second dose. Neutralizing antibodies appear in 95% of the recipients, and duration of long-term immunity is not known. That's all about mumps virus. And next one is measles, that is caused by rubeola virus. Measles is an acute, highly contagious childhood disease, which is very common in childhood days, which is characterized by fever and respiratory symptoms, followed by typical maculopapular rashes. Pathogenesis. Mode of transmission occurs predominantly via the respiratory routes, either by droplet inhalation over short distance, which is the commonest method, or small particle aerosols that remain suspended, especially in schools, hospitals, and enclosed public places. Spread. How this virus spread? The virus multiplies locally in the respiratory tract. That is, it is mainly present with upper respiratory tract infection. A characteristic maculopapular rash, first on the neck and then spread to rest of the body. Now, the route of spread. Multiplication in the respiratory tract. The virus multiplies locally in the respiratory tract, then spread to regional lymph nodes. Enters into the bloodstream in infected monocytes causing primary viremia. Further multiplies in reticuloendothelial system, spills over to blood, that is secondary viremia, disseminates to various sites. Target sites. The main target sites of the virus is predominantly seated in the epithelial surface of the body, including the skin, respiratory tract, conjunctiva, and CNS. Again, once again, the route of transmission, that is multiplication in respiratory tract causing high fever, rhinitis, and cough, which then invades the bloodstream, disseminates to reticuloendothelial system, and the final target sites include skin, mouth, respiratory tract, conjunctiva, and central nervous system. Various conditions associated with measles is shown in this figure. Clinical manifestation. Incubation period is about 10 to 14 days, which may be shorter in infants and longer in adults, and the disease is divided into 3 stages, that is prodromal stage, eruptive stage, and post-measles stage. First one is the prodromal stage. You can see in this picture rashes all over the body and various symptoms. The first stage, that is fever, is the first manifestation, occurs on day 1. Complex spot or pathognomic of measles appear after 2 days following fever, that is on 12th day of infection, and characterized by white to bluish spot surrounded by an erythema, appear first on buccal mucosa near second lower molars, rapidly spread to involve the entire buccal mucosa and then fade with the onset of rash. Non-specific symptoms which may be present such as cough, coryza, nasal discharge, redness of eye, diarrhea, or vomiting. Once again, about complex spot. Complex spot are pathognomic of measles, appear after 2 days following fever, and they are characterized by white to bluish spot surrounded by an erythema, appear first on buccal mucosa near second lower molars, rapidly spread to involve the entire buccal mucosa and then fade with the onset of rashes. Now, the eruptive stage, that is maculopapular dusky red rashes appear after 4 days of fever, that is on the 14th day of infection. Rashes typically appear first behind the ears, then spread to face, arm, trunk, and legs, then fade in the same order after 4 days of onset. Rashes are typically absent in HIV infected patients. If we are noticing the time lapse, that is fever is seen on the 10th day, complex spot on the 12th day, and rash on the 14th day. And the last stage is post-measles stage. It is characterized by weight loss and weakness. There may be failure to recover and gradual deterioration into chronic illness. These rashes are due to cytotoxic T cells attacking viral infected epithelial cells. In next 10 to 14 days, rashes fade with considerable desquamation. This complex spot appear at the end of the prodromal symptoms and just before the rashes. Again, about the oral manifestation of measles, that is complex spot on buccal mucosa, palatal and pharyngeal petechiae, generalized inflammation, congestion, swelling, and focal ulceration of gingiva, palate, and throat. Complication, various complications, that is primary complication is secondary bacterial infection. Following measles, there is profound immune suppression and fall of cell-mediated immunity, which in turn predisposes to various secondary bacterial infection. Otitis media and bronchopneumonia are most common. Recurrence of fever or failure of fever to subside with the rashes is also seen. Worsening of underlying tuberculosis with a false negative Mantoux test. Giant cell pneumonitis, acute laryngobronchitis, that is croup, diarrhea, leads to malnutrition, etc. are also seen, along with hepatitis, subacute sclerosing, pan encephalitis, etc. Now, There are certain other complications, that is post-measles encephalomyelitis, measles inclusion body encephalitis, subacute sclerosing panencephalitis, etc. SSPE belongs to group C slow virus infection caused by a defective measles virus. Now, laboratory diagnosis. Specimen nasopharyngeal swab, that is respiratory specimen nasal secretion or blood. Antigen detection by using anti-nucleoprotein antibodies. Demonstration of virus multinucleated giant cell. Complex port biopsy. Direct immunofluorescence antibody test. Isolation of virus is on monkey or human kidney cells or Vero cell line produces CPE as multinucleated giant cell. Antibody detection in serum can be done. Serology, reverse transcription PCR detects viral RNA. Prophylaxis, passive protection. Normal human gamma globulin given within 6 days of exposure. Then live attenuated vaccine given by itself or in combination as MMR vaccine. Recommended age is 9 months. Airborne precautions such as isolation in the negative pressure room, use of PPE such as N95 mask, etc. must be followed while handling measles cases. Live attenuated vaccine is available for measles. Most attenuated strains that are in use currently are derived from original strain isolated in 1954. Measles vaccine is available in combined form with rubella, that is MR vaccine, with mumps and rubella, that is MMR vaccine, and with varicella, MMRV vaccine. Next one is respiratory syncytial virus. Respiratory syncytial virus is a major respiratory pathogen of young children and is the most common cause of lower respiratory disease, that is bronchiolitis and pneumonia in infants. This is a highly contagious disease. Mode of transmission. RSV is spread by direct contact, that is contaminated fingers or fomites, and by self-inoculation onto the conjunctiva or anterior nares, or by large droplet inhalation. Incubation period is 4 to 5 days. No viremia is seen and outbreaks are usually in winter. Pathogenesis. RSV replicates locally in the epithelial cells of the nasopharynx and may spread to the lower respiratory tract to cause bronchiolitis and pneumonia. Again, multiplies in the mucous membrane of the nose, spread to lower respiratory tract, bronchiolitis and pneumonia. The major pathology is that lymphocytes in large numbers migrate to the site of infection and secrete several cytokines which cause the following changes, that is peribronchiolar infiltration of inflammatory cells, submucosal edema, necrosis of the bronchiolar epithelium, and formation of plaques consisting of mucus. RSV causes a wide spectrum of respiratory illness. In infants, RSV is the most common cause of lower respiratory tract infection below 1 year of age, causing bronchiolitis, pneumonia, and tracheobronchitis in 25 to 40% of infected infants. It begins with running nose, fever, and accompanied by cough, wheezing, and dyspnea. Adults, RSV produces influenza-like upper respiratory symptoms such as common cold, running nose, sore throat, and cough. Infections are common in overcrowded communities. RSV can also cause exacerbation and worsening of asthma or COPD, that is chronic obstructive pulmonary disease. Recurrent infection is common in both children and adults but is much milder. Laboratory diagnosis. Direct identification of viral antigens in clinical samples. Direct immunofluorescence test and various serological identification. ELISA is used. Reverse transcription assay, that is RT-PCR amplifying viral RNA, and antibody detection. Treatment. Aerosolized ribavirin or ribavirin plus hyperimmunoglobulin. There is no vaccination available. Monoclonal antibody versus fusion protein is a choice. Supportive care is also needed. that is such as removal of secretions, administration of oxygen, bronchodilators, and ventilatory supports. Immunoglobulin with high titers of antibody to RSV was used in the past but was found ineffective and hence it is not recommended currently. Actually, ribavirin is the drug of choice. It is indicated for severe infection in infants. However, its beneficial effect in older children and adults are doubtful. It is administered as aerosols for 3 to 6 days. Oral ribavirin is not recommended. This is all about respiratory syncytial virus. Thank you.